You know, spirituality is a part of nursing. And if you are spiritual, I mean, you are with the heaven, divine power is there with you. When you are doing something good, divine power is there, and that gives you intuition. Okay, next. Women's rights. I think somebody else is going to talk about RMC, है ना? अलग से है, फिर भी मैं जल्दी से I quickly I'll do this. Next, respectful maternity care. Our White Ribbon Alliance is doing a lot in that, and in that it comes. We should recognize that okay, she is a mother and she is जननी. बट बड़ी बड़ी बात करते हैं इंडिया में जननी, लेकिन उसकी हम परवाह नहीं करते हैं, वो नहीं करना है. Okay, next. Okay, why these universal rights came? Freedom from harm and ill treatment, because physical and mental abuse happens. Many people have said it, and we know it, and we are here to not to let it happen. That is why we need to give them respect to maternity care, right to information and consent. Do we take her consent for whatever we are doing? We don't do that. We need to do that. Written consent or verbal consent, or ask her permission to do anything. Then confidential and privacy. Same thing. Once we went to Hamidia Hospital, Bhopal, Dr. Prakash Amma and our team, and mother was exposed like this. The khidki samne thi. People can say, "My God," we got so annoyed and upset. We went and met the medical superintendent and the HOD. Everybody, ki, what are you doing it? You can do this, but still. So that reminds me ki how mothers are being treated. So we need to be sensitive to that. Okay, dignity and respect, equality, no discrimination. In other countries, it is the color. In our country, it is the poor and rich. So we should not make any distinction. Please, we need to keep this in mind. This should be put somewhere that we keep in mind. We have to practice that. Okay, timely care, liberty, autonomy, choice. Okay, anyways, next. How we do it? Respect their beliefs, etc. Okay, you all know it, and maybe again this will be talked about, so I'm not going into that. I think time is also going. Okay, next. Next. There is scientific also evidence also that if you give RMC, respectful maternity care, it contributes in assuring positive outcomes for mothers as well as babies. She's not scared. She's not. Her hormones will work in proper way if we are respecting her and giving her the due respect that she deserves. And if we do that, cognitive development of babies in later life, it helps. All these things are helping. There is lot of research available in this area, but it all depends on us to practice it. Okay, next. These are the key stakeholders. We all are responsible. What we say, we all are responsible. Okay, next. Same thing, similar. क्या करना है? Next. So I have finished here. Anybody has any question from me? Yeah, I wanted to show you the book. This is the book, Miracles of Motherhood, and this is based on our experience in Choithram, starting first conducting the OPDs and then doing research and then having the birthing center, natural birthing center, where working there we all enjoyed. I'm sure Sushmita will agree with me, and I think you were also there when we were having this. So so when I got retired, then I thought ki I don't have much work. I can do this, that I can create a book, because it will, whatever we did, it should go to other more people. So I wrote this book, got it. The sketches were done by Varsha, who is now in Qatar, and one more person. And we were very happy. And I'll tell you the story of this book. It came very costly to me, something more than 2 lakhs I spent. And then Mayor Group of Drugs, they purchased it. I was just talking to them, and they said, okay, this book, I will, how many copies you have? I said 500. He says, I'm purchasing all. I said, it's costly. He says, okay, 550 rupees. Okay. and they purchased it. By then, I had already given to people. I have left with 300 books. So gave them 300. They again placed the order. So more than 500 books they have purchased. Then motherhood hospitals, they came to know about the book, and they also asked me, we have 22 hospitals in the country, can you give one each? I said, all right. So they placed order and they got it. And like that, my whatever I spent has been come back, has a comeback. I put it in the Malik publication. My own publication house is Malik Publication, where I take out the journal as well as ये उठा के दिखाओ जरा. I'm showing you because you should get little motivated. That is, this journal was coming twice a year in Choithram Hospital, and then I said कि इसको चालू रखना है. तो कहते हैं कि hand over the ownership. I said the person whom you are telling me is not capable. So they said we will not give you money which is with them, 2.5 lakhs. I said all right. So I started my own this thing. Publication house, Malik Publication, on my father's name, and I started publishing the journal. And then I took out this book also. दिखाओ वो book छोटी सी. See, there is another book that we published. These are 11 stories from 11 different nurses, shorts, anecdotal stories in the form of a book. इसका नाम है Nursing Epiphanies. Epiphany is divine manifestation. We all nurses are divine because we do God's work. So this is, and then after that, this book. So you don't have to sit at home when you retire also. You can go on doing many things. and now for me, for next 4 years, I've got the work of Somi, me and Manju and Leela Varki and all of you. We will, and today, after 4 years, we will again come together and say where we were and where we are now. Okay, so thank you very much. Anybody wants this book can call me.
Thank you, ma'am, for your inspirational words. This will definitely enhance our knowledge towards it. Due to some busy schedule, Professor Dr. Usha Okande ma'am have to leave us now. So I would like to request our principal ma'am, Dr. Archana Chauhan, to present a memento to Professor Dr. Usha Okande ma'am. Thank you, ma'am.
Now I would like to request Manju ma'am as she wants to share some thoughts with us. So please ma'am, welcome.
There's nothing new, but I wanted to thank before leaving, and I would like to thank your director, Sir Bajpayee, who is a very versatile person. I have a discussion of 10-15 minutes, but have understood him completely. And I wanted to appreciate your principal, Archana ji, at this age with vibrant personality as well as thoughts out of the box thinking is what I appreciate. And I think out of the box helps us, everyone. And I also wanted to tell you that in my slide, there was Garb Sanskar app. You can download that app, but if you have to utilize completely, there's some payment they ask for. But that app is developed by one of the gynecologists who is a Brahmakumari. They work on those spiritual things. So Garb Sanskar app, and your doctor Archana ji has already used that app during her 9 months. So that's the practical example. You can interact with her later on and understand how was that app, and it helps a lot, that I'm sure. So that was another piece of information. Thank you for being wonderful audience, and clap for yourself.
Thank you, ma'am. A lunch a day keeps the worries away. I think majority of people agrees with me at the moment. Am I right? Everybody might be anticipating for lunch. So, sometimes a lunch break works wonder. So I request all of you to enjoy your lunch and we'll be back with our scientific session after 45 minutes. So all of you are requested to enjoy your lunch. And once again, we'd like to thank you, Manju ma'am and Usha ma'am, for sharing their time with us. And we are really blessed to have them with us. Thank you, ma'am. Good afternoon, all. Welcome back to our scientific session. I hope everyone have enjoyed our lunch. And आप सभी लोग आप satisfied हो अब next session के लिए. So we are about to begin our next session.
Giving birth should be your greatest achievement, not your greatest fear. Now is the time for our next scientific session. For that, I would invite Dr. Adela, Manager and Leader, Darzi Fellow, to share her valuable knowledge with us on introduction on hydrobirthing and the procedure and setup of hydrobirthing. She is an interest in supporting and developing midwives to improve women's health as well as women's birthing experience. I request ma'am to please start her session.
Good afternoon, all. Can you hear me clearly? It's lovely to be here in Lucknow. I'm Adele, and as you can see, I'm here today to talk to you about hydrobirthing. I want to tell you the story of how I came to be here today. In 2011, I was working at City University in London, and my lovely colleague Rashna Chinoy was a consultant, and she worked at Barts Health's medical school, St. Mary University. And we'd worked together because I had an ambition to train medical students and midwives together. And so I got to know Rashna, and she said to me one day, I have a friend in India, she's looking for someone to train midwives. And I said, I'm your man or your woman. So I ended up coming to India, and I had a lovely experience of meeting a group of students and developing midwifery education. Andy and Becky had started teaching a small batch of midwives. My background was in midwifery education, So when I arrived, I saw there was a lot of spaces to fill in. One of these spaces was students needed objectives, structured, they needed a portfolio. So over the weeks, I followed these students in practice. And I told them then about labour in the classroom. Then I'd teach them notions of research, and little by little, a curriculum was born. Normally in England, in universities, we sweat, we cry, we scream, and we develop a curriculum for nursing or midwives. Mine was done very quickly. I'd no one to fight with, no one to worry about pleasing. We did our own thing. So I'm also going to say a word about change, because I think in everything we've heard today, we're talking about change. So that was one of my most lovely experiences of my life. Why? I had intelligent, bright, caring, willing to learn students, and that's all a lecturer wants. So I followed them to labour ward, and I saw some things that were very different. They were nurses working in the hospital in the labour ward setting. So the women were in the bed, and I'd say, "What's happening? Why the leggings?" "Oh, leggings, ma'am, perhaps cesarean." "Jyoti, it's 41 degrees. No leggings, no leggings." Okay, so we progress. "Jyoti, what's this?" "Oh, light, ma'am." "Don't be rude. Don't look at the woman there. Switch the light off." "Oh, ma'am." It was okay. Jyoti and I still stayed friends. So what happened next? "Betadine. From the umbilicus, no, from the breasts to the knees." "Oh," I said, "gross infection, Staphylococcus, Staph aureus is in the air in India. What is this?" "Oh, ma'am, she's going to birth." I said, "But she might birth normally if we'd stop doing the pathology." "Oh, ma'am." So then some people were very happy. As you know, one of the things stops us changing birth is cost. Cost effectiveness. Doesn't it ring in our ears? All our health ministers like to think about money. So this is one very good reason we need to sell midwifery care to obstetricians and health ministers and all the financiers, because it will make them very happy. So as soon as the director of the hospital, who had invited me to train her midwives, saw that I was saving money with the betadine, she was very, very happy, because they were using litres for one normal birth. And she said, "This is saving me so much money." So little by little, we made birth normal. Next thing I said to them, "What's the clock in front of the woman's face?" So the woman's in the labour bed, she's looking at the clock. So the woman's having contractions every 5 minutes. She looks at the clock and thinking, in 3 minutes, 2 minutes, oh, one's coming. And there's adrenaline, and there's cortisol. And what's it all doing? Fighting the oxytocin. The contractions, they get worse. Especially since all the nurses talk about painful labour, the pain of labour. So it's all a very tragic situation, isn't it? And the tragedy is, we need to do less to do more. What is it they said? The art of midwifery is the art of doing nothing well. And that's what we mean, being non-interventionist. Right, that's the end of that story, but wait for the next part. I've got lots more stories. So, I'm Adele. I'm from the UK. I have trained as a nurse in the Ulster Hospital near Belfast. I went to Scotland to train as a midwife in Irvine in Ayrshire. I then went 14 years to Switzerland, was 23, had good memory then, so I was speaking French within about 12 weeks. And I stayed there 14 years, and then I became head of midwifery education at Geneva. At that time, I did my management course and a teacher's training course in French. Then I came back to Northern Ireland because it was a time when nursing and midwifery was going into higher education and getting degrees. So I said I need a degree if I'm going to teach. So I did a degree in health studies at Queen's University Belfast, then went to Dundee, started my master's in education, moved to Nottingham University and worked with Professor Diane Fraser. I wrote chapters of Miles' midwifery textbook. My chapters did not have the label pain in labour. You can well imagine I don't talk about the P word. It became support and comfort in labour. So then after Nottingham, I had a serious illness and I said, oh, I need to get to the family quicker in Ireland. So I moved to London where there's every hour flights to Belfast. And I was a lecturer in practice and I had a lovely year working in labour ward, teaching all the midwives. And at that time, I was the first lecturer in practice and we started teaching students clinically. And my memory of the teaching here in India was worked. Why? Because I taught the students in labour ward all day. We had half the group then from 3 to 5 for a session, the other half from 5 to 7. Half the group went to night duty to work. I went to the wards to see what was happening, and then we did the same all the next day. So we were all friends, and that's why we understood the practice and we understood the knowledge together. So we need practice-based education. I envisage low-cost, effective, good education by a few excellent practitioners in practice. They can have a program, they can assess practice, they can assess the knowledge, we can develop interesting practice-based assessments, problem-based learning, and get away from the problem which we had where I was teaching. We don't want students to stress over writing an essay in English. We don't want an essay. We want some good knowledge base. So we have to think of interesting and simple ways to assess. And as you know, all education starts with assessment. You work backwards and then you make sure you're assessing what you taught. So then after working as a practitioner in the labour ward and teaching, I went into the City University as a senior lecturer and programme director for direct entry midwifery. Those are students with A-levels, the qualifications to do a degree, and they do a 3-year degree in midwifery, specific and only. And everything we teach, psychology, sociology, biology, is applied midwifery biology. And that's how we get through. If you're thinking you need nursing skills, of course we need nursing skills, but appropriate ones and the right ones. So we sent student nurses to A&E so that they can see the experience of mothers who arrive in emergencies. We send them to medicine so that they can see diabetes and care for people with diabetes. So that extends their horizons and they understand also how a bigger hospital looks. Otherwise, midwives are only interested in community care and the labour ward and their clinics. So they need to see the full spectrum. So after working at City University, I did my PhD. And at the time in London, I was asked to do the Darcy Fellowship course. What is the Darcy Fellowship? To me, it's going to underpin everything I say today. Lord Darcy was a former health minister. He maintained the problem about the NHS is one of leadership. As was said this morning, we are all leaders. It's not in our title, but you can be sure in your midwife, if you're a midwife, it's in your JD. It's in your job description. Whenever you go into that room, you are leading. Whenever you're giving care, you are leading. You all need to think about how I'm going to implement change and how I'm going to set up new services and do different things. So implementing change, for example, in that time, I learned a lot about the history of health services, all the different health services in the world, commissioning and financing. And the other thing was we had to do a project on change. We were taught a lot about change and how not to change and the mistakes that have been made and what we've learned. One of the things that I'd learned was force field analysis. So for example, if you think there's problems implementing midwifery care, you're always going to see barriers. Oh, these people don't work with me. Oh, the fear of the change. We fear everything, most of all, change. Then you've got the bright midwives, you've got those who are knowledgeable, you've got the woman who had hypnobirth or hydrotherapy or hydrobirthing, and the midwives are pushing the change. So what you do is you forget all those who are pushing against you, you take all the positive energy and you push the field in one direction together with those who will work with you. It's actually saying, don't worry about the people who don't come with you. In the end, they might be convinced when they see the change, or you leave them behind and eventually they'll have to join. That's a bit strong, but making change is so difficult, and that's all I want to say. So with my background of nursing, midwifery, and education, that was how I was invited to Hyderabad and made very successful changes. 2011 and 2012, we've now got fabulous midwives with 10 years experience, and they are shining role models of modern, contemporary midwifery practice, evidence-based, caring, even affectionate. Lovely midwives. So we need more. So the project at the moment is starting to set up educators, and we are envisaging training more midwives. So there's a lot of change. We're now being invited to other states to do the same thing. And that's why I was invited back to see the changes at Easter. And now I've come to help implement and see how we can change midwifery. So today, I've been given the topic, Introduction to Hydrobirthing, Procedure and Setting Up of Hydrobirthing, to present to you. So here we go. Someone rightly said, without our past, we've no future, which is why I'm including a short historical backdrop and a mention of some of the events that led to the inception of midwifery-led care and water birth today. Surely today, with all our knowledge and resources, we can look, listen, and understand what sorts of experience women want and need, but also what they deserve. Women in the past times went into the water for relief, the tide, the water, instinctively, and they sought out and found their own personal, low-cost, readily available hydrotherapy. Women listened to their bodies, and we in turn have to listen to women. After clarifying some of the terms we use when we talk about using water for birthing, I will explain the principles and procedures surrounding hydrobirthing. I've chosen to focus on the needs and the care of the woman, the requirements for caring properly and safely for women using water during labour and birth. So, the terminology. Where's my word not coming? Oh. Oh, I didn't cost. No. As a finale, I'll tell you some stories of women who've had a water birth with Fernandez, and you'll see for yourself how women express themselves and their experience of hydrobirthing. Oh, yeah. I think that's it. Yeah, it's good. It's good. It's good. So, the terminologies. There's nothing more relaxing than a warm bath, and many people use hydrotherapy in very different ways. Why then is water not used especially for women in labour? It's drug-free, it promotes relaxation, and relieves stress. So when we say hydrotherapy, it's the use of water to relax, to give comfort. And water birth is the word we use just now, that a woman has had her baby in the water. So the meaning of hydrobirthing and water birth are the same. So a historical backdrop. Historically, in the warm waters of the South Pacific, women were drawn to the sea to birth. In most traditional societies, the rituals and practices of childbirth have, until now, been a matter of secrecy and handed down through the generations to women. We haven't learnt about these stories, unfortunately, and haven't been able to learn from them. There's oral traditions of similar practices among the Maori and the Indians of Central America, as well as the Greeks and the Egyptians. By 1805, the first account of use of water in Europe had been documented. A French woman who had laboured for 2 days before being encouraged to get into a warm bath by her doctor progressed and gave her birth normally. Water birth was pioneered in the 1960s by the Russian researcher Igor Tchaikovsky, and using a large aquarium, he installed a glass tank in his own home in Moscow, and it gave relief to many birthing women. And this event was published in the West, and the photographs inspired the first water births. The first water birth in India recorded was in 2007. So back to France, our very significant Michel Audin. Sorry, I'm having bother with my... Where's the beginning of my... What's the beginning of this? So a key figure in the use of water in labour and birth is from France, the obstetrician Michel Audin of international renown. He's a midwife's hero. In 1977, Audin installed a pool in the hospital of Pithiviers in France, not with the idea of promoting birth in water, but primarily as another way of providing relief to women and rest during long, difficult labours. I will quote him, he has said, the reason for the birthing pool is not to have the baby born in the water, but to facilitate the birth process and to reduce the need for drugs and other interventions. Audin published his findings in The Lancet, and his recommendations in this article provided the basis for the first midwifery water birth guidelines, and they were published in 1983. Michel Audin was an obstetrician. He went to the north of Africa. He was French, so he had to participate. He was called up to do military service. And as he was an obstetrician, he was interested in birthing. He noticed the women in North Africa. They were clinging onto trees, keeping upright in labour. He saw how the births happened more simply, more quickly. The labours were shorter. So he said, I'm going to take this back to France. So he went back to France with this inspiration to change birth for women and provide them comfort. So when he got back to his clinic, he set up water birth. Skipping to the present, you can see the first water birth at Fernandez Hospital in Hyderabad, here in India. And this is the team, and as you can see, the event was home-like, family-friendly, inclusive, and just a great success. One in a long line of water births, and that's still continuing in Hyderabad. Of course, as midwives gained experience and expertise, and also they extended their role, and they enjoyed the support of their leader, and they were able to extend their role. So eventually, a midwifery-led unit was required. So it was planned, investment was found, planning and training was needed, the environment was prepared, the clientele was prepared, the midwifery team, the obstetric team, and all the supporting structures. Until finally, in 2019, the proper setting for hydrobirthing evolved and is now in existence, a midwifery-led unit. Just a word about midwifery. Midwifery is not an annex or an add-on of another program. Midwifery is a profession, an autonomous, independent profession. And the midwife acts and gives care in every situation. If it's an emergency, the midwife acts until medical care arrives. She does have that expertise to act in all the obstetric emergencies, shoulder dystocia, PPH, neonatal resuscitation. She knows and has all those skills. She has psychology, sociology, biological, all those knowledge bases. So midwifery is a profession by itself. So we have started an MLU where midwives work independently and work with low-risk women. This picture shows you the entrance to the MLU, the midwifery-led unit. Geography is very significant. The co-located unit improves safety, but there's an ever-present temptation to move staff to labour ward whenever labour ward is very busy and there's hectic days. I heard my colleagues say to our obstetric visitors the other week, and this door is very significant. The door denotes the clear cut-off between the obstetric unit and the midwifery-led unit. But there's always a door. Midwives care for women in the obstetric unit and give midwifery care to the satisfaction of women, and of course, the obstetricians. Doctors are our colleagues, they are our friends, and we have to have good teamwork. So now I'd like to show you the data in our midwifery-led unit. And as you can see, since the end of 2017, a total of 775 women have been able to enjoy midwifery-led care and hydrobirthing hydrotherapy. Those women who used water during labour are represented in red, and those who actually give birth in the water are depicted in blue. Obviously, COVID-19 affected the numbers somewhat. However, hydrobirthing continued as it is safe. The mother is in an individual room, and she has one carer, and this is how and why this trend continued. As you can see, the graph shows this year results will show around 60 hydrobirths and over 120 hydrotherapy in labour. The data is resuming the clear increase in the numbers since pre-COVID. So it's improving all the time by word of mouth. Oh, I want to go back one. No, it's good. So this is about the available evidence on water birth. So what do water births do? The evidence is clear. Hydrobirthing and water birth are safe. It reduces the needs for opiates, epidural and other pharmacological assistance that we use in labour. This in turn improves the efficiency of labour. Therefore, labour is shortened. The natural helpful movements of the fetus towards the outlet of the pelvis occur. The rotation of the head is facilitated by the water and also by the relaxation of the pelvic joints. The pelvic floor tone is intact and functional. It's not affected, for example, by an epidural, which results in it becoming inefficient and toneless. In this state, the pelvic floor is unable to flex the head when it comes into contact with it. Then, what happens? The diameters of the fetal head are not reduced. The larger diameters of the extended head find it much more difficult to descend and are more harmful to the woman's soft supporting structures and tissues, the muscles and ligaments of the pelvis. Perineal injury is less likely in water birth or hydrobirthing for these reasons. The normal contraction of the uterus continues after the birth, and also PPH and hemorrhage are less likely. Babies' outcomes are improved also as they have a normal and physiological birth, no induction of labour. Their respiratory systems adapts. The mild hypoxia that all babies, this is very interesting physiology. The mild hypoxia that all babies have at the end of labor encourages them to swallow. None of us is able to swallow and breathe at the same time. Breathing is inhibited until the first swallow has taken place. As well as this, the dive reflex closes off the glottis of the baby to abnormal substances. So what we're saying is babies can't drown, so that fluids cannot be inhaled into the lungs. And we know that a lot of babies have a lot of distress after the birth because they swallow a lot of amniotic fluid and have a very hard time for the first day swallowing, breathing. Even their eyes look bloodshot. They look very stressed and unhappy. It then follows that the well-being following birth is optimized and readmission for both mothers and babies is lesser. Now I want you to do one thing for me. I've explained to you the baby's descent. It's encouraged and normal progress occurs with water birth. Why is that? The baby's head descends and rotates. So I want you to do like this with your fingers. Everyone, 3, 2, 1. This. Some people are with me. I'll go with you. Put your hands like this, right? I want you to put your fingers round your head. Is that a big diameter or not? Is that a big diameter? Right. Now I want you to put your finger on your nose on chest, fingers the same, measure your head. So is this smaller or is this smaller? There's a big difference. This way you've got your head flexed like the baby. So if flexion increases in labor, the diameters are smaller, and I've actually seen it. The baby nearly jumps down a centimeter whenever this descent and flexion and rotation occurs. So you're facilitating this. You're facilitating this when you get the mother up. You're facilitating this when you get the mother on all fours. You're facilitating this when the mother is in the water. Yeah? So, an overview of the evidence. What does hydrobirthing or water birth increase? It's happening to me again. Help. Where's the beginning of my story? Oh, wait a second. Just like this. I always want the top. I went to the top.
It will come only this one.
Right, you have to be ready to save me. Obviously, maternal satisfaction is improved with a good birthing experience. Mothers are relaxed, informed, feel in control, they're better to cope. Physically, the outcomes are improved. We've been talking today about mental health. So today we've got a greater awareness of women's mental health needs. Where's my thing going?
You have to do it slowly now.
Physically, the outcomes are improved. Perineal outcomes are better, also for the reasons that I've said to you. You've been looking at your head, flexed head. So as well as this, at the birthing of the baby's head, and the mother... Sorry, technical issue. So we'll go back. Physically, the outcomes are improved for the mother. Perineal outcomes are improved. They're better also for the reasons given above. As well, the birthing of the baby's head, the mother awaits the crowning of the head, and this gently stretches the perineum. Therefore, there's no force, there's no aggression, and the perineum remains intact. The perineum thins out gradually, and it avoids tearing as the baby's head slips out and is moving. I'll show you a video, and you'll be able to have a look at a baby being born. You'll be able to see this later for yourself. The mother has enjoyed her hydrobirthing experience, then she'll be more disposed and receptive and able to adapt to motherhood. She'll be able to bond with her baby. And as we also give immediate skin-to-skin contact, this also develops the mother-baby bonding and improves breastfeeding. And in water birth, we've got this great opportunity for the mother to experience crawling. So we just put the baby on her. She can wait until the baby itself will move towards the nipple and will go onto mother's breast itself. It's a reflex. The only reason why we don't observe it, we don't wait in maternities and don't give baby the time. So, suitability criteria. I'm not sure if we should be using these terms like criteria, but anyway, this is a list of some of the things to keep in mind when we're getting involved in hydrobirthing. The age of the mother, of course, normal onset of labor, overall observations must be normal. Baby should have normal parameters. Normal hemoglobin levels are important for all laboring women, but even most so for mothers who are going in the water. All mothers with a BMI less than 35 should be able and eligible to go into water. For example, women with pre-labor rupture of membranes wouldn't be eligible for the pool because they might be requiring, what would they be requiring? Maybe antibiotics, yeah? Therefore, it's a medical model. So, what do we need? Not a lot. Low cost, as I was saying. A water thermometer, a waterproof Doppler to listen to fetal heart rate, a small net or a strainer or a sieve, small handheld mirror and maybe a torch, a pair of long gloves for the midwife, and emergency equipment. We just need to know the location and that it's functional and keep that in mind. Maybe also non-slip mats and also a kneeler for the midwife for her knees. She might be kneeling by the side of a tub. You could also remember that a trial run or a test might be very helpful or useful to get people to see how water birth functions, and if they do a trial run, it builds confidence and it trains staff. So this is hydrobirthing in a home in its correct setting in an MLU. So just look at the space. The room, the privacy is ensured for the woman. Safety is provided by curtains to cover the entrance. The bed is not the key fixture, therefore it's against the wall, there if needed. The bowl you can observe and other useful items are all available. You can see the rope, we call it, to help the mother support herself upright if that helps her. And it reminds us also of the influence of Michel Audin and all that he's done for maternal health and midwifery care today. And this is the room from the other side. You can see the door into the bathroom. The mother has an ensuite bathroom. You can see all the equipment from the other angle. And if you, as you'd noticed before, there is a curtain in front of the door so that the mother has complete privacy if the door is opened. So the environment's very home-like, it's agreeable, and it reduces stress and induces relaxation and facilitates the woman's coping. Other considerations, safety and other things. So space is important, room to maneuver. It provides comfort, but also safety and movement and access is important, especially if there's an instance such as the water becoming more cloudy. The woman may have to exit the pool so that it may be determined whether what the cause is, whether it's blood, meconium-stained liquor, or some fecal matter, and we can empty the water and refill the water with clean water. The woman may need to come out of the pool at that point. Of course, no electrical appliances if we're using water for safety. And the technique. So we start filling the pool. We keep the pool at body temperature, 98.4 degrees. Prepare the room. As we've heard today, there's lots of other techniques that we can use in conjunction with water birth. Aromatherapy, low lighting, music, a chair for the birthing companion so that he can be involved. The woman can wear what she wants. She can wear a hospital gown, she can wear her own t-shirt, or she doesn't need to wear anything at all if that is her choice. We must ensure that she has got complete privacy and feels at ease. We don't fill the pool too high. We cover her bump. Remember, the water level will increase and rise once the mother gets in. We help the woman into the pool. We need to record what time the woman went into pool, especially if we're going to do some research later and we want to compare and look. So we need to keep good notes so that we're able later to collate data and look at different effects, times and effects of the water and the hydrotherapy on the birth, the speed of birth, the type of birth that the mother ends up with. You know, we can look and see if less tears occur whenever a mother does this, or there's blood loss is decreased. We've noticed in some births. So it's very important to note the time so we've got good information. Encourage the woman to mobilize in the water, just in whatever way she wishes. Switch off the AC, gla gla gla, and the fans. And the birth companion can use a jug and assist the woman and make her more comfortable by pouring water over her abdomen. We monitor the woman and the baby as you would any woman on land, all the maternal observations and the babies. Good documentation. The midwife needs to remember to get ready. She may be a little bit wet. The hint is in the name, water birth. We provide a chair for our birth companion so that they can be in prime position, be participative in the birth. We can encourage the mother to eat and drink and also to provide energy. If the membranes are intact, we observe for spontaneous rupture of the membranes in the water. It'll change color. And when the woman has the urge to push, we encourage her to listen to her body and find the position that she wants. For some women, this is kneeling, all fours, or squatting. The woman will not feel a strong urge to push because she is more relaxed and more in comfort and in tune with her body. And she will not take a deep breath in and push. She'll just make gentle pushes. Make sure the water temperature is still correct all along. If not, remove a little bit of water, add warmer water, and continually control and look at the temperature of the water. If the water gets dirty, there's little particles, remove these with the sieve and keep it in a clean, safe environment and an agreeable environment for the woman. There's no need to provide perineal support or any intervention, as the woman is doing her birth all on her own with the presence of a midwife. Due to low lighting, you might want to have a torch to have better visibility, or let the mother see her perineum if she's pushing. Here, let me mention also, of course, bladder care. The woman can get out of the water at any point that she wants. If you want to examine her, if you want to listen to the fetal heart, you think you want to listen for a longer period, or if the woman wants to pass urine, she gets out of the water and can go back in. Entonox is also used in conjunction with water birth. Here's one woman using Entonox. Does anybody know what Entonox is? Its other name is laughing gas, 50% nitrous oxide, 50% oxygen, pre-mixed, and it's a very effective analgesia in labor. It's been used for 50, 60 years, no longer, in the UK. The only thing is the midwives mustn't leave it in their car because if it freezes at night, it won't be mixed. It will unmix it. So it can be used at home, but we have it piped and we use it in our maternities. So this woman's using Entonox. The other thing about the use of Entonox is she's breathing slowly and deeply, sucking in the Entonox and breathing it out. Breathing in, she can use a mask or a mouthpiece. She breathes in and out deeply and slowly, and it calms her respiration. And one of the things we do when we get agitated is we breathe quicker. Then that's going to increase our heart rate. That's going to increase the heart rate of the baby. So this calmly keeps the mother calm and keeps her breathing calm, increases her oxygen levels, and baby also won't get tachycardic because the mother's pulse is staying normal. So prenatal care, hydrotherapy, suitability of women is talked about. We try and do a campaign of awareness and explain to women that if they're interested in hydrotherapy, hydrobirthing or hydrotherapy, this is now a possibility. And this passes word of mouth, and that's why our numbers are increasing. We give information, we give choice. I brought with me today, and some of you may want to have a look at our own information leaflets. In the UK, this is a requirement. When we have a new guideline for people, we must make an information booklet or paper that goes with the information that is evidence-based that the professional uses. We make a friendly one then for our women, in our case, and for patients in hospitals. So if anybody wants one, they can have a look. So this provides nice woman-friendly, woman-centered information to women, and we can also use it to explain the role of the midwife so they also become aware. Because we've also on a campaign to develop awareness and sensitize people to the wealth and the extent of the role of the midwife in India. And we've heard this morning the amount of things a midwife can do for women antenatally, even about preconception, preconceptual care, birthing care, and post-birthing. So we facilitate shared decision-making, and we've got the perfect setting in a maternity-led unit, and we explain this to the woman. So in the first stage of labor is from the onset of regular, rhythmic, painful uterine contractions that affect the cervix to full dilatation of the cervix. So this is the time the woman is having contractions. Her muscle is working. I think that's a nicer way of putting it than the P word. So in the first stage of labor, we review the plan, and that is maybe something might have occurred and the woman may need some extra care, or we need to make sure that everything is safe and well, that she can have hydrobirthing. It's not completely a no-no. Maybe she can have hydrotherapy if she can't go ahead and have hydrobirthing. The usual assessment of mother and baby and abdominal examination. Intelligent intermittent auscultation means this is a low-risk woman, everything is well. We do not need to listen to the fetal heart. If the woman is very comfortable and the labour is progressing well, we need to keep regular observations, but this is not a pathological case. So we keep an eye and we assess progress carefully and document well. We keep the team and our colleagues informed of progress as well. For the second stage of labour, and second stage of labour is from full dilatation of the cervix to the birth of a baby. It's good to have 2 midwives present, if possible, at this point, but not all units, as you know, not all hospitals function in the same way. So you might not be able to have 2 units. Protocols differ, and it depends what the hospital requires. The woman can adopt the position that they want to. Labour progresses with gentle encouragement, some instruction, and the woman is more likely to push physiologically and more likely to have a hand poised or hands off birth. So, as we said this morning, we're doing minimal intervention, not interfering. Spontaneous birth of the shoulders will occur, and we just let the birth occur and happen normally. The baby is born under the water, and it's important that once the baby comes out of the water, that the baby does not go back in. The baby's time of birth is noted, and at 1 minute, the APGAR score is recorded. Babies born in water are less likely to cry. They have a continued supply of oxygen through their umbilical cord, and they're likely to take longer to become pink all over. So for this reason, we must take the APGAR score at a true 1 minute. Midwives always don't record the APGAR at 1 minute. Sometimes we think it's a minute and it may only be 30 or 40 seconds. We need to give the baby a minute to adapt to its extrauterine life. So the baby is then brought to the surface, and as I said, it'll not go back to the water. The baby is placed on the mother, and skin-to-skin contact will induce bonding. Breastfeeding is started, and the baby can crawl and across to the mother's nipple and start breastfeeding. The baby will be able to smell the mother's scent. The baby knows the scent of her own mother from the Montgomery's tubercles, the sebaceous glands around the nipple, and the baby will go to the mother's nipple and start sucking. That is, if we don't interfere with the baby's smell and put perfumes and disinfectants, and the baby knows and smells its own mother. But you know very well, there's a lots of smells that will interfere with the baby's smell. Cord clamping is delayed. We saw the advantages of this morning. The baby will get 60 mils, up to 60 mils extra blood, and then this will help it through the first month of its life. And the baby will have less risk of being anemic in its first weeks of life, and this is especially important in India, where there might be some needy babies, and they need the extra blood at birth. Then the cord is clamped and cut when the pulsation has stopped. So the third stage of labor. Third stage of labor is from the birth of the baby, the expulsion of the placenta, and the control of bleeding. So the third stage then will also be physiological. Why? Everything that has preceded has been normal. So the uterine contractions are normal. With the contraction that births the baby, there may be some blood from the fundus of the uterus. The separation of the placenta occurs with the birth of baby's head. So at that time, that large contraction that births the baby is separating the placenta. The placenta is coming down into the lower uterine segment. And as we're working with physiology, we will probably have a very simple, straightforward physiological third stage. We need to observe and see that the bleeding is normal. If the placenta is being retained, it's very simple. Sometimes even getting up and getting out of the pool will dislodge the placenta, and it will birth normally as the mother moves and as she gets out of the pool. If that doesn't work, then the mother will lie down. We may need to try a bit of controlled cord traction and help the third stage. But normally, breastfeeding is being initiated, and that will also encourage a normal third stage of labor. Once the mother is out of the pool, we measure and document the estimated blood loss as accurately as we can and record that. That's other interesting data that we can keep now that we're going to embark on carrying out water birth. We need to keep good records of what happens in the first cases so that we're able to build up a picture of what it does, what it improves, etc., etc. Perineal examination to see what the outcomes are and reassure the mother that everything is fine, but also keep that documentation so that we're able to use it in the future and build up a clear picture of the outcomes of our water births in India. I think these images speak for themselves. It says it is, but right. I just can't see it. I can't see it moving. I don't think so. No.
But it's running.
That's it. Watch baby's head. Look at baby's head. So there you can see the reduced amount of effort the mother had to make, how gently the baby was born, how easy it was for the mother. And normally a baby's head, the face sweeps the perineum and baby looks like this and it puts his head, you were seeing this part of baby's head. Then inside the shoulders have to rotate round into the AP. And in that, it was all so fluid that those shoulders weren't in the AP. They sort of slipped out semi-AP oblique. But the mother did not tear, and she had a very good experience. And now I want you to see what mothers said about their birth. But for those who still need convincing, the what-ifs, let's quickly look at these. What if the mother needs more pain relief? Well, we provide it, but we won't be giving opiates and we won't be giving epidural. So the mother may need to change position, she may need massage, she may need to step out the pool for a moment. The midwife will ask herself the question, why is she having more pain? Is the baby going to be born in 2 minutes? That's a trick, especially with a multiparous woman. My colleagues sitting know very well. You have to watch the woman carefully. Sometimes the end of labor can progress very rapidly, and the mother says she has a lot of pain. It's just because it's getting very rapid. In the case of fetal distress, the midwife fully assesses fetal well-being. She will note the fetal heart rate and the temperature. If she needs further examination, she will contact the neonatologist or call for help. But first of all, she will step the mother out of the pool and do full examination and assess. Then she will see what needs to be done next. In the case of hemorrhage, reassure the mother, get her to lie down on the pool. The placenta may be in or out. She can step out. If there is hemorrhaging, it may be because the placenta is on the way out and there is a lot of bleeding. By the time she steps out of the pool, this can actually dislodge the placenta. It is born, then contractions can continue and the bleeding will cease. If the mother needs any help with the placenta that is retained, we will get the mother out of the water and put her on the bed and go through the normal protocol for a retained placenta. The same with eclampsia. The mother's actually safer in water. We just keep her airway. She'll be moving around in the water. If she has a fit, it will pass. We will observe the fit. Once she is able, we will step her out of the water, assess her blood pressure and her well-being, and call for the necessary help as we would for any mother. Shoulders dyssocia, similarly. The problem will be resolved in many cases when the mother steps out of the pool, because the posterior or the anterior shoulder, the one that is jammed, will be moved, and then the shoulders will be able to be born in many cases, because the mother is moving, lifting her leg, and then the shoulders will be born and baby will be born. Newborn resuscitation we will carry out. We will have the equipment. The midwife will know where the equipment is. In the water, vaginal examination is, if necessary, can be carried out in the warm water and is probably a lot more comfortable for the woman. As our colleague said this morning, she is relaxed, the water is warm, and it's a lot easier on the woman. So I would like to finish my talk today from those who do know about hydrobirthing. Surely the experts in water birth and hydrobirth are those who have experienced it. We need to listen to women. I don't know if you know the song in India. It's swept across Europe. I'm your mother, listen to me. Anybody know? Well, I'm not your mother, but listen to me, and even more so, listen to the woman. And then? Oops. Can we get this slide? Is she talking?
It's a video.
Where's my, I want this ladies to talk. There's a little, embedding a video seems such a good idea, but practically,
Hi, I'm Stuti Kanori and I delivered my son at Stockholm through water birth. The midwives and the doula really made the process so much easier for me. They made me understand, they educated me on the process of water birth, as to how it's going to be, and it was really relaxing and calming. It had a very calming effect on me during during the delivery, and I think it was so much easier. I don't think I could go any other way.
so would any of you be able to tell me the sorts of language or the words the woman described her birth? How did she describe her birth? She said the words used were easy. I was able to understand. It was really relaxing and calming. She said calming twice. Think about the words and the terms we use. We complicate, we use medical jargon, we use woman-unfriendly terms. All this is unreassuring for women. But this woman sounds like an empowered, joyful, fulfilled woman. And I've another.
as soon as I got into the pool, it was such a relief. You know, it's just similar to how when we jump into a swimming pool, we feel very light. And because it was a water birth, I think I was able to enjoy the last few seconds just when the baby comes out in a much better way. Probably, I think if it was not in water, I don't know how that I would have taken that pain, you know, because of the water, the numbness that is there around the area. The baby just made a somersault and it flopped out. And as soon as the baby comes out, the sense of relief that dooms down on us, and magically you see the midwives held the baby and they bring it up from water, and it was a very relieving thing to just hold the baby and to hold the baby close.
So that's what the lady says about her birth. What words did she use? Relief, a feeling of being light. Did you ever hear of that? A woman in labor feeling light, maybe lightheaded. Buoyancy made the woman feel light, the effect of the water. She says that the water numbed the birth canal. So we're saving more money. We don't need local anesthetic because the water is anesthetizing. This is what the mother says. This is her expression. She was able to enjoy to the last. So even the most difficult part of the birth, this large diameters, the birth of the head and the shoulders, she said it was easy. Her words were somersault and the baby flops out. We tell women, take a big deep breath or push as hard as you can. The baby slipped out. That was her idea. The baby flops out. Those are lovely words to express your birthing experience. And these are the words a woman chooses to explain her experience of hydrobirthing. How good is that? Thank you for listening.
Thank you, ma'am, for blessing us with your expandable knowledge and experiences with us. Thank you, ma'am. Now, I would like to request our principal, ma'am, Dr. Archana Chauhan, to present a memento to Dr. Adela, manager and leader, Darcy Fellow. Please, ma'am. Thank you, ma'am.
ये वाला है
What arrangement you have? Anything else? It's fine. Anything else you need?
Shall I call you, ma'am, first? I'll present you. It's okay, ma'am. हाँ खोल दो ओपन कर हाँ Moving towards our next session, carrying a baby is the most rewarding experience a woman can enjoy. I think each and every woman believes this. Carrying a baby itself is a rewarding experience for each and every woman. So I would like to call Ms. Karen Bratton, International Midwifery Educator, Walsall, UK, to share her valuable knowledge with us on antenatal exercises towards normal birth. She is having 21 years of nursing and midwifery experiences in UK. So, ma'am, please.
Thank you very much. Thank you for your welcome. And firstly, I would like to thank all those who have organized this conference for inviting us. Thank you for the people who made the beautiful flower arrangements and the food and the sound and the technical everything. It's all been wonderful. And especially the one thing I love about India is your color. You brighten up the world. And I often think, wow, I am walking among princesses. All your clothes are so beautiful. It's amazing. So thank you for your welcome. And thank you also. Thank you also for having this conference, because the day we stop wanting to learn something new is the day we should be retired, or even past that. Because even when you're retired, there's so much you can learn, so much you can do, and so many new things happening all around the world. That's great to share all the experiences. So in the UK, as well as India, childbirth could be much improved. I feel sometimes I'm a fraud. I'm coming from the UK. You must think UK is wonderful. But actually, many people stay on the bed for the whole birth. We have many sections. And so all through the world, we are trying to improve childbirth experience. We're trying to reduce section rate by encouraging physiological birth, natural birth. So this whole conference is about how can we do that? So all of you, in your small ways, you can do something. This morning was full of very inspirational people. They went against the flow. Yes, somebody is telling you to do it this way, but if you know this way is better, you have to stick out your neck and say, no, evidence says this is better. Evidence says, I'm going to be kind to the woman, even though you laugh at me. Kindness is one of the main things that improves maternal satisfaction. And we want competent kindness. So this afternoon, we are doing some antenatal exercises. So because we've been sitting a long time, I would like you all to stand up and do some exercises. So first, with an easy one, we'll do arms. So we'll do arm stretch. So another one we like to teach women is a figure of 8 with your hips, okay? So a figure of 8, first one hip, then round, this hip, like this. Come on, Elsa. Okay, lovely. We'll do some more in a minute, but this is just to wake you up. Thanks. So, my name is Karen Drayton. I'm a nurse from the UK. I have just general experience in nursing in the labor room, and I have done some obstetric emergency courses in Bangladesh and Africa. So last December, there was a job opportunity for me to come to India. So because I was actually born in India very many years ago, probably twice the age of you, so I thought, this is lovely. Let me come to India and use my skills and love living in India. So I'm working with Jipaigo, which is an NGO, and Jipaigo won the contract from the government of India to run a midwifery program. Like Dr. Ashok said this morning, the government of India want to introduce a new cadre of midwives between nurses and doctors. So we'll be specialists in childbirth. So this is somewhere, when you have completed your training, you can come and be a midwife, only midwifery. And we can do all these wonderful things like water births and all these different methods to make sure cesarean rate is decreased. So how the program runs, there are 19 national midwifery training institutes in India, 4 for Jipaigo, 1 in Meerut. Renata will speak from Meerut. I was from Wardha in Maharashtra, and we trained 30 students. So Sheetal is one of these students who came to Wardha from Bhopal in Madhya Pradesh. So a national, bringing people from all over to then go back to your home place and then spread the word. So cascade training. We trained 30, Meerut trained 23. Now these 53 people are also training other people. So we would love if you come to join us, men also. We love male midwives. So when you can apply to the state and then you can join our training program at an NMTI. So we'll do some exercises now. Sorry. So Sheetal is going to introduce herself.
Good afternoon, all of you. I'm Sheetal Sani, National Midwifery Educator from Jabalpur. I have completed my BSc Nursing and I have 3-month residential training from ICU training from Narayana Harudayalaya, Bengaluru, and 6-month residential training from MGIMS, Mahatma Gandhi Institute of Medical Science in Sevagram, Wardha. And I have completed my 12-month mentorship from Jabalpur. And now I work as a national midwifery educator in National Midwifery Training Institute in Jabalpur. Okay, so now today we are going with our topic is antenatal exercises. So our outline session is introduction, benefits, contraindication, type of exercises, demonstration, and conclusion. And that session leading by our international midwifery educator Karen, and I am here for demonstrating some antenatal exercises. Okay, you can.
Thank you. So just to introduce, the main definition of antenatal exercises is to improve the physical and psychological well-being of an expectant mother for labor and preventing pregnancy-induced pathologies by various physical means. So Anjali is another midwife educator in Jabalpur, and we have a childbirth education room with lots of information. And here we have 5 mothers. So we have group teaching of antenatal exercises and all the other advice that we like to give antenatally. So the benefits of antenatal exercise, they improve blood circulation for the mother and the baby. So the more blood going around the mother's body, the more the baby gets oxygen, the more the baby gets the nutrients. The more exercise you do, it strengthens your heart. So the mother then will have more stamina for labor and will be able to cope better. It can reduce blood pressure, one of the major problems in pregnancy. It can lead to more controlled weight gain. So yes, you gain a bit of weight in pregnancy, but if it is controlled, there'll be less chance of having diabetes, gestational, and type 1. Also, it can reduce the common ailments of pregnancy. So when you do a maternal OPD, many people come with many aches and pains. So what exercise does, it helps the body posture to change shape and the weight of pregnancy. So you have less muscle ache and less cramps. So people complain about muscles, but the more you exercise, the less problems there are. Women often complain about constipation. Exercise is always good for constipation. Sometimes you have insomnia and disturbed sleep. Again, exercise is very good for improving that. Exercise also for all of us improves mental health and mood and reduces stress. This is one great thing in pregnancy. You want to be nice and calm. Put only calm thoughts towards your baby. And it reduces incidence of varicose veins also. So many, many benefits. So only contradictions that we can see. If the lady is having vaginal bleeding, abdominal pain, leakage of fluid per vagina, then we might discourage antenatal exercises. However, in our hospital, when a woman comes in labor and her waters are broken, the doctors say to us, no, don't move that patient, her waters have gone, she needs to lie flat. And we say, no, there is always enough water left. She needs to still mobilize because we need to deliver the baby faster. We need to encourage her to move and for the birth to progress. Also, other contraindications can be dizziness or headache, chest pain, calf pain or swelling, or muscle weakness affecting balance. Advice about antenatal exercise. You need to keep well hydrated. Avoid exercises lying on your back for too long. Avoid exercises lying on your tummy. Avoid abdominal crunches. Allow for some flexibility, but gentle abdominal work is important and can stop the baby weighing down on the bladder. So just wear loose clothing and start gently. Obviously, some people do a lot of exercise before they're pregnant, so then they continue at the same rate. But if women are just starting with general day-to-day activities, it's better to start gently. So this slide is very busy. I don't expect you to see it, but it shows that there are different exercises recommended by trimester. So the first trimester can be a bit of a vulnerable time, so we don't suggest too much vigorous exercise. Nice core strengthening exercises and relaxation. And yoga is also good. In the third trimester also, we don't want to induce labor too fast, but we want people to be fit for the process of giving birth. So we can divide the types of exercises into 5 main types. First is breathing, second, circulatory, third, stretching, fourth, relaxing, and fifth, strengthening. So when we're going to do our exercises, we need to prepare the environment. So it's good to have a large space, yoga mat or some surface on the floor, ensure privacy, ensure there's light and ventilation, and you can do as a group or individually. So let's start with some more breathing exercises. So this morning already you did lots of deep breathing, so another chance to do this. So let's all take a deep breath in through your nose, with your back straight, shoulders down, and out through your mouth. And again, in through your nose, out through your mouth. In through your nose, and out through your mouth. Apparently, babies are the best at breathing. They use their whole lungs right from the beginning of birth. But as we get older, we use less and less and less of our lungs. So it's always good to take deep breaths, especially when you're stressed, when you're rushing around, when you're worried. Deep breathing is excellent. So then we move to circulatory exercises. These are to improve circulation and venous return. They stretch and strengthen calf muscles and decrease those cramps that pregnant women complain about. So you can do this in your chair also. There's 3 leg exercises. You probably don't have much room. The first one is from the knee raise your legs like Sheetal. See if you can raise it as far as you go. Yep, let's do it 5 times. Ready? 1, 2, 3, 4, 5. Okay, next one is from the ankle, just ankles up and down, up and down, up and down. So we'll do that 5 times. 1, 2, 3, 4, 5. Excellent. And the last one, we can do some circles with your ankles and feet. This is all great. Everybody can do it, any age, to keep your circulation going. Lovely. Then you can go the other direction. That's right. Then we can put your hands to your shoulders. Sorry if it puts your elbow in somebody's eye. And do some shoulder rolling. And when you do it inside, then breathe in, and then back, breathe out. In and out. In and out. See, you're already feeling better. So excellent shoulder rolling. So now we will do some shoulder circling. I think probably you can't do this. You can be tilted. We'll do big circles without hitting your neighbor. So we can do this 10 times. Then we can go the other time forward. Okay, excellent. You're doing great. So next we're going to do some, yes, Adela can show us lots more. You can do small circles or big circles. You can make up whatever you like. So now we're going to do some squatting. This is very good for a pelvic floor, as we said before, and it improves circulation of the legs, decrease swelling, and decrease cramps. And up again. Up. So you can hold it as long as you can. Yes. Yep. Lovely. So leg stretching too. Because we don't have a wall, I'm going to be the wall. I'm a wall. And Sheetal is going to stretch.
My hands are straight and that leg straight. I feel stretching here.
And the second one we can do against the wall.
I feel stretch here during that exercise. And pushing ball.
So when you get home tonight, you can do pushing the wall, okay? See if your house is very strong or not. The third leg stretching exercise can be lying in supine position and lifting up one leg. So try not to arch your back. Your back should be flat. Hold your leg for 6 seconds. 1, 2, 3, 4, 5, 6. And then you can do the other leg. So obviously, because the womb is pressing on the aorta, you shouldn't lie on your back for too long. But it's good to stretch all the muscles in your legs. So then this one you are expert at already. Side arm stretch for stretching, deep breathing, and calmness. So we'll do it again. And then we'll do a side stretch. So side stretch. And then the other side. Thank you. Next we have a standing lunge. So you ask the women to raise one bent leg onto a low service and move forward to stretch the thigh and straighten the leg. So that's right. You bend forward, straighten the leg, and it stretches. Squatting with the help of a partner. So squatting is good. You can also do squatting down the wall, and you can do many other things. So butterfly pose. Put your feet soles together. Hold your feet, and it stretches your thigh and your groin, and it can relieve pain and fatigue. So nice and slowly. And it helps facilitate smooth delivery when practiced until late pregnancy. Next, we have cat and camel. This stretches the neck and the shoulders, alleviates stiffness, and keeps the spine flexible. So this is a lovely one to do. So this is the cat. With your head up, chin up, and then your back down and then up. And then the back is nice like a camel. And it just relieves all the tension in your back. So up and down. Lovely. So this is my favorite one. And just to show that we actually do this in our childbirth education room. This is Sheetal with one of our mothers doing Viparita Karani, where it relieves backache, improves the flow of blood to the pelvic region, and eases swollen ankles and varicose veins. So I think you did this yesterday, talking about dysmenorrhea. It's a good position to have as well. And just to say it is possible. So when you are looking after antenatal women in the ward, you can perhaps say, let's go for a walk, let's do some yoga. Another good pose is Shavasana, which relaxes the body and repairs cells. So as you think about all the different parts of your body, from your head to your toe, it can all relax and everything is calm. And this helps general mental health as well as physical health, and you can avoid taking the medication and relieve stress. Thank you. So next, we can do lots of birthing ball exercises. We can do the round hips. So when a woman is sitting on a birthing ball, the pelvis is being moved and it's becoming more flexible. So in a pelvis, you have all these different ligaments, which mean it's not a fixed pelvis. In too many textbooks, we think it's fixed, but actually there's a lot of movement in it. So the more you move, the more the outlet can get bigger, the baby can nestle into the proper place, into its good position. And when you're in labor, then there's more space. The outlet becomes bigger with different maneuvers, which Renata will talk about. So just to say that the pelvis is very flexible, and we need to try and improve that flexibility. So by getting women to do birthing ball exercises, they are opening their pelvis like this. And like that figure of 8 you did, that's also really good. Okay, so we can do round and round, we can do side to side. So in these pictures, one of our midwife educators was having a baby in July 17th. So this is her in labor, and she had a lovely baby in our midwifery-led unit. So obviously exercises also can help change babies' malpositions. So on Wednesday this week, this lady, Aruna, in the yellow sari, she came and she said, my baby's breech. So we taught her some positions to help change the baby's position. So on the left is side lying release, and this one, forward leaning pose. So we can also try these kind of things to make a breach into cephalic, and then there's more chance of normal birth. And this is the lady having some side lying position. The leg drops off the table, and we put some pressure on the pelvis to help the baby turn. Then we can do lots of massage according to the woman's preference. Some women like firm massage, some like it light, and some people just get fed up over everything. Pelvic floor exercises, I think you talked about these yesterday also. So we can encourage these anytime in pregnancy to help strengthen the pelvic floor before and after childbirth. And lastly, talking about good posture. So Sheetal is going to give you 2 demonstrations. Is this a good posture? No, it's not a good posture, is it? Show us a good posture. That's right, so straight up. But women often go like this to compensate for their big bump. So we try and encourage women to stand up tall and have a good posture. And the whole aim of all these exercises is to help women give birth in more comfortable positions. So we have to talk about labor before they come in labor, otherwise they will think, no, we are going to sit on a table and be flat on our backs. So if you give them some information before the birth, then they will be ready to have birth in different positions. So we are sitting on a birthing stool, and in Warta, this is their most favorite position. And we have many, many births on birthing stools. So just to say some feedback. So the students we originally worked with in Warta, one of them said, in 19 years of clinical work, a mother has never before thanked me for the care she received. So this is shocking, isn't it, really? And I think it's all about kindness. It's all about really being interested in that person, treating that person as an equal, not somebody, oh, I don't know her, so I'm not going to give her proper care. So once we engage with the women and communicate well, then people are very grateful. Another one of our students was really good at talking. So she would bring all the early labourers together, and she would talk to them all about labour. She would give them lots of information, and then she'd get them all doing lots of hip rotations and everything. So as a group, even in early labour, we can do that. And this one sort of sums it up. She came to the antenatal education room. She knew about labour, about exercises, and she said she was now looking forward to the birth. So instead of fearing the birth, people look forward to it. So in conclusion, pregnancy exercise helps strengthen muscle tone in preparation for delivery and rapid restoration of muscle tone after delivery. The goal of any exercise program should be safety and the improved well-being of the mother and fetus. Promoting adequate oxygenation, placental perfusion, venous return, and positive emotional state are all elements of a well-rounded program. So to gain the advantages of exercise, women need to do it at least twice daily. You need to encourage them when you see them in clinic, see if they're doing it, and see if you can encourage more exercise. Any questions? So this is your task for tonight. You can do this pose when you get home. After you push the wall, you need to lie on the wall with your legs up in the air. Thank you very much. Thank you.
Thank you, ma'am. Thank you so much, ma'am, and Sheetal Saini, ma'am. So I would like to request our principal, ma'am, Professor Dr. Archana Chauhan, ma'am, to present a memento to Karen, ma'am, and Sheetal Saini, ma'am. Thank you, ma'am. And thank you, Karen ma'am and Sital Seni ma'am.
Moving towards our last session, today's last session of scientific session. So,
I need this. I need just I need all.
Okay, yoga mat also? Yeah, okay, okay, fine. Leave it here, leave it. Anything else? Ma'am. हाँ, इनकी सुन भी है? हाँ, इनके साथ भी है। दुपट्टा वो रेडी रखना, दुपट्टा फिर से ले लिया एक दुपट्टा। हाँ, कोई नहीं, हम तो आराम से बुलाते ही नहीं। नहीं, कोई चीज़ नहीं, ये हमें या तो पहले बताते कि हमें अरेंजमेंट करना है, तो हम चीज़ें कटोरी में लगा देंगे। No, it's okay, ma'am. Anything? It's okay, comfortable. Please have a seat, ma'am. First, you can present here. बोल दो। एक मिनट। ठीक है।
And my comments is here, yeah? But where okay, when the no.
ठीक है। Birthing is the most profound initiation to spirituality a woman can have. Now is the time for our last scientific session. For that, I would invite Miss Renata Grablinian, International Midwifery Educator, Lithuania, UK, to share her valuable knowledge with us on natural childbirthing, the the continuum of labor and positioning in this context. She is senior midwife and a line manager for the last 5 years. And Miss Florence Magdalene Darling, international midwifery researcher, is supposed to join us virtually, but because of some personal issues, she couldn't join us. So, ma'am will be continuing. Ma'am.
Good afternoon, everyone. So, my name is Renata, and I'm the senior midwife
for the last 15 years, and I was practicing in UK in a freestanding birthing center where we had 5 birthing rooms set with the pools. And there we look after the woman, no doctors around, only midwives. And we empowering our women to be as natural as possible during their birth, and to do whatever they love to do, and we are there to support them. So as I had this experience and I heard about India, that they are establishing this project with the midwifery care, I was really eager to come here and to share my knowledge. Also, we just been mentioned that Florence, who could not attend, she was my teacher actually, who showed me different approach to the birth. And she told me that birth can be natural and normal if we allow this to happen. We don't really need to do much. We really need to trust the process and allow things to happen just to support mother. And when I came to India and I entered labor rooms and I observed what is happening, so in the government settings is not that picture what I would love to see, but slowly that picture is changing now. We established our MLCU unit in the district women hospital in Meerut, and for the last 6 months we are supporting our mothers in with the natural normal vaginal birth, and only midwives are there, nurse practitioner midwives, and they are supporting our mothers in different position and with a different approach. So let me talk now about maternal position during birthing process, and let me introduce the objectives. So at the end of this session, the participants will recognize the factors affecting progress of labor, different birthing positions, evidence and fact about upright position and care, and we will summarize everything at the end. Maternal birthing positions, what is that? What do you know about maternal birthing positions? There was one study done about the home birth, and women were allowed to do whatever they feel is good for them when they were in labor. And all women, they went to the darkest, smallest place, the coziest place, and none of them adapted themselves on lying on supine position. None of them. All of them were some of them went on leaning forward. Some of them went on kneeling position. Some of them went just walking around. Some of them were sitting. Some of them were dancing. But none of them lied down on their backs. So that is important to understand that woman's body tells her what to do, and we really have to listen, and we really need to empower our mother and say her, you listen to your body and you do what your body tells you to do. Because woman's body in labor knows the best position, and she knows the best what is good for her. So what is the birthing position? So that is position what woman's body adjusts herself during the birthing process and during labor. And the position has a direct effect on the non-medical intervention to facilitate spontaneous progress of childbirth and must be offered as a choice to women. This is recommendation of the World Health Organization, and it's like from long time this recommendation, and then it's repeated again 2017. So what I can say, you can see in this picture, mother in different positions, and squatting on hands and knees, with the birthing stool, standing upright, resting against the birthing wall and lying on her side, walking, also one of these upright positions. So woman can be horizontal and can be vertical in labor. So the most recommended position is upright position, vertical. Some of the horizontal can be on the side lie, then it's as well recommended and beneficial for women. So now just have a look into the factors, what influences the normal progression of labor. We have 4 P's, power, passage, passenger, and position, and then extra 1 P for psychological support. So what is the power? Power is the mother, her contractions, how strong these contractions, how often they are coming, how long they are lasting, are they mild, moderate, or strong? How for how long they already like carry on, like for 1 hour, 2 hours, 12 hours. So this will give you a picture to understand that which situation this mother is, yeah, in which position. And this can be very much affected also by the mother's age and her parity. It very much affected. So now passage. What is the passage? Is the shape and of the pelvis. To be honest, I didn't know before. I knew from the textbooks about pelvic inadequacy. In in India, there is like very common reason for cesarean section, just because mother has inadequate pelvis. But there are so many researchers saying that, you know, baby should fit the mother's pelvis, and it's just the level of ligaments actually, they and the flexibility of this pelvis which affects, but not bony part. Let me show you. So here is your pelvis, which is flexible. We have symphysis pubis, we have iliac bones, and we have this joints which is connecting these bones, and they are flexible. And why they are flexible? Because of the relaxin which is released during pregnancy for this joints to be softer and more flexible. So when baby is in the position and you move pelvis, baby just easily goes and rotates. Baby doesn't stuck. Actually, baby rotates. Baby screws into the pelvis before baby is born. Yeah, so this way. Why pelvis can be inadequate? In India, it can be because of during puberty, during the teenage age, not mothers, these girls, when undernourished, they did not receive enough microelements, not enough vitamins, so their pelvises, they are not well developed. This might be one of the reasons why these girls has narrow pelvises and inadequate for their babies. So for this, I do accept and understand. But most of the times, it's the matter of ligaments, really, and joints, not the bone part. So passenger, what is important about passenger? We say it's passenger, but with the newest research, it says that this baby is a passenger, but it becomes a driver. And this is the baby who goes through this passage. And baby starts all this process, most of it. What we are looking for, that this baby, on palpation, we can find what is the presentation, lie, and the position of this baby. During vaginal examination, we can find any molding, any, other findings which can affect the smooth birthing process. So now position, force P stands for maternal posture and physical position of the mother, affecting anatomical and physiological structure. That's why maternal position is very important, what position she will adopt herself during birth. And the last one, psychological support, pregnancy and birth experience. So during pregnancy, how was she feeling? What support she has at home? And is this baby is being wished and expected very much in family? Maybe she has, or maybe she has some previous bad experiences. So it can affect during this birthing process too. And has the mother had, good preparation for birth? And already been told today, like presence and support of birthing companions. So I'm going back to this bony part of the pelvis. So if you look at this picture, you can see that there are counter notation and notation of the bony part. So counter notation increases inlet, yes, so the part where the baby is going into the pelvis, and the nutation increases the outlet. This part. So if you apply pressure on pelvis, it will. If you apply pressure on the iliacus, then this outlet will increase. Then this coccyx will bend backward. Yeah. So this makes extra space. Sometimes it says 2 to 4 millimeters, even up to 1 centimeter. It can increase the outlet. So angle is matter. So it's very popular, this ketchup bottle. If you want the baby out, well, if you want the ketchup out, you need to tilt the bottle up, yes? So same with the mother. It just look at it, the angle. In the picture number 3, mother is lying on her back in lithotomy position. and the angle and the pressure of the baby goes straight on the mother's back, and this doesn't allow this coccyx to flex back. Yes, so it's like counter pressure. And on standing upright position, there is a different angle, and baby can freely go through. Same as you see ketchup, when you tilt it, it freely comes out. So now let's think about the baby. There are main vessels which supplies baby with blood and oxygen. And they are at the back of the mother's the spine. And the baby, if mother is lying on her back in supine position, giving the lots of pressure on this vena cava and the aorta, and the supply of the oxygen is reduced. That's why sometimes we have a fetal asphyxia and fetal distress. So lithotomy position compresses vessels, reduces uterine blood flow. And that's why we encourage mother to be in upright positions. All right. So now I will ask my assistant to do some exercises. So how I would like my mothers to sit on the chair. So she needs to open her legs this way. Her feet should be inwards. So this increases the outlet. So even if you yourself, you can do exercise. You open your feet to the sides, and you can feel how your muscles and the ligaments in your bottom stretching and closing. And if you move your feet inward, you can feel your outlet is opening naturally just by changing the angle of your feet. Yes? So in this upright position, very easy. That is not expensive. Anyway, you know, these positions can be created. You just need some chair, armless chair for the mother to sit. So she can lean over the bed or the table or the anywhere, and then it's easier to reach her and do some back massage and apply some hip squeezes. And it's very comfortable for mother, especially if the baby is OP position, occipito-posterior. Baby can not give that pressure on this backbone, so it reduces pain. Same, other position, she can go on her knees and lean over the gym ball, or just rest on it this way. Thank you. And here you can see the pictures is from midwifery-led care unit in Meerut. We have created this space for the mother, and here the first picture, mother is sitting upright on the chair and resting forward. The second picture, mother is lying on her side and resting on her side, and you can see the peanut ball in between her legs. If you have no peanut ball, you can use a pillow just to keep the legs apart. The third picture is mother is leaning over the beanbag, and the midwife is behind her. And on the fourth, it's a squatting position. Squatting position became very much popular in our MLCU. I just found that Indian woman doesn't like to be on kneeling position. It's very difficult to put Indian woman on her knees, but she is very happy to go on squatting position, and this position she loves. I will show. when you're in the same level with the mother, supporting her with her squatting, she feels that safety in your hand, and she trusts you. I just had an experience when I went to labor room. Mother was lying on her back. She was primigravida, 5 to 6 centimeters dilated, and she was lying on her back. And the situation around her looked like very much she is useless. She has no power. She was so distressed, just lying alone. And I was thinking, how can I help this woman? How can I approach her? And in the beginning, it looks like, you can't do anything. It's just like, but slowly, I went to that woman, even without Hindi, I went into that hard conversation. And slowly I took her off that, couch lying on her bed and encouraged to just to stand stay in upright position, maybe just to lean forward. I gave a little bit of massage, and then I started to see changes. And then I offered her my hands, and I went and did the squattings with the mother. I would say maybe within the next 10-15 minutes, her waters has gone. In another 10 minutes, we noticed this vertex visible. So you see, it was not much, but mother changed completely from being useless, like without any uh, power, into the woman who feels strong and who can control what is happening, just because someone is supporting her and allowing her to use her strength. So next, my slide, now I'm going into the evidence. And this is like a very important part what I'm coming to. Loads of like research is done, very high quality and not very good quality, but there are plenty, hundreds of material about positions in labor. And what is interesting about that, so all this looks at some few main components. So how long is that labor last? In different position, what is the baby's condition? How it's affecting the baby's condition? Then is that mother needed any episiotomy, or has she sustained any tears? Then they look at the length of labor and about the bleeding. So these main components, if you have a look, so now this slide is from a learning package resources which was created by JPIGO, and it says they are using this Cochrane review and meta-analysis, Gupta et al., combined the results of 32 randomized controlled trials that included more than 9,000 birthing women in hospital settings. In comparison with non-upright positions, women who were randomly assigned to upright position in the second stage of labor were 25% less likely to have a forceps or vacuum-assisted birth. So why do you think that women will have less instrumental deliveries? As we know, because of the angle, isn't it? The baby has more power to go, to descend, and to go through the birthing passage. Then when woman is in different position, I would say it's less likely the intervention will happen because by the time she is moved to different position on her lithotomy, the baby might come out naturally. Also, I have one example when a woman was said that she has inadequate pelvis and she is going for cesarean section. She was 4 to 5 centimeters prima gravida. At that time, we had a photo shooting for our MLCU, and we needed a mother just to show some antenatal exercises and to have someone who can we show the different birthing positions. And because at that moment there were no available mothers, the labor room staff, they said, okay, you can take this woman because anyway, she is going for cesarean section, so you can do exercises on her. So we took this mother to our unit and we did antenatal, different exercises for half an hour. And we sent that mother back to labor room and guess what? She has delivered within the next 45 minutes. So all that story about inadequate pelvis just vanished. It was lovely to see that. So if we go for the next, less likely to have an episiotomy, 25%. There is a practice in UK, no, I'm sorry, in India, that for the first time mothers, they give routinely episiotomies, even if there is like plenty of evidence saying that this is not recommended and natural tearing is better. So why, let's say, we think, why it is less likely to they have this episiotomies? So again, by the time mother will change position from upright to lithotomy for the doctor to be able to reach and give that the episiotomy, baby normally is out. There is no time. That's why it happens. And 55% says less likely to have abnormal fetal heart rate patterns. As we noticed from the previous slide about the vena cava and aorta, we know that if mother is lying on her back, baby is giving pressure on these vessels, and this not supporting the supply of the oxygen to the baby. And the next one is 20% more likely to have a second-degree tear. So what is this? There are lots of different kind of research saying that upright position, especially on the chair birthing or squatting, can increase second-degree tear. But this is in one hand. We know that perineal tears happens to the first-time mothers very often, and there is percentage about maybe 70% even. So this, in one hand, this increases amount of second-degree tears, but they do not receive this routine episiotomies. So you see, instead of having this episiotomy, they have this perineal tear. So it equals this situation. And 48% more likely to have estimated blood loss greater than 500 mils. But it is less than 1,000 mils. So also there is a possibility that women might bleed a little bit more. So in this situation, midwife just should know what to expect and be ready. What we were doing in our birthing center in UK, so we've been encouraging our mother to sit on the birthing stool till the vertex visible, till the vertex is crowning, and then the last moment, move her on kneeling position. kneeling position supports perineum or side lie release supports perineum. So then we just suddenly move mother, and it's really not difficult to move mother from sitting on the chair, moving on her knees. It's very simple, and it can be done. And this is the way how we can support these perineums. Also, there's the reason why they say why this perineum tears happens, because midwives are unable to support perineum in this position, and it could be the reason for this also. So more benefits of upright position. Uterus can contract more strongly and efficiently, shorter lengths of active pushing phase, and there is less risk of compressing aorta and vena cava. The fetus can get in better position to pass through the pelvis. I already show you what happens with the bony part. Baby just screws into this pelvis, and when mother is mobile and upright, there is more gravity works on it, and then it helps baby to do all these maneuvers inside and go through the passage. And the other is less pain lying on the back. It's very interesting, because on the pain scale, they did some also research, and on the pain scale, the mothers measured how strongly they feel this pain, and they said that it's significantly less pain when they are in upright position. Sometimes I can notice that women can feel a bit more pain when she is on the side, but what is possible to do, just keep changing this position. She doesn't need to be all the time in the same position. She can, be mobile. And there is even one song saying, like, if you want to move the baby, move the mother. Yes, so it's very important to understand that when mother is stuck in one position, baby might move much slower. And when baby mother is moving her hips, is she upright position, then baby will move through the birthing passage much smoother. So now how there was even counted that the second stage of labor can become shorter from about 6 minutes to 9 minutes. And in some studies, it says even up to 34 minutes shortens the second stage of labor, especially with the squatting position. This is related to the woman's in some cultures, and especially as I noticed in India, the woman is doing lots of squatting in her daily life. She is washing floor, she is going defecate into the toilet, this position. So all this encourages her outlet to open and just for baby to be born. I wanted to show some research from India, because it's very interesting to see, in different parts of the world, there are different findings. And in India, there was a prospective cohort study done in Baroda for 1 year by the group of obstetricians, and they published this research in the British, not this Indian gynae journal. So what was the findings? In healthy antenatal women, adopting an alternative birth position was associated with a shorter second stage of labor, as I already mentioned before. lower visual analog pain scale score, and then more satisfaction. That is very important point. What we normally looking for, that mother should feel empowered. Yes, and this, when mother can adopt a different position, she feels that she is in power, that she is the, how to say, the strongest point in the bus. She is not passive, and doing whatever nurse or doctor telling her to do, but the doctor is doing and adjusting itself to what mother wants. So it gives more satisfaction and empowerment to the mother. And again, it's less need for episiotomy and the high Apgar score compared with adopting lithotomy position. Okay, so next one. I was talking about all the positive facts, and now we just have a look what are the adverse effects of supine and lithotomy positions. It is, oh, sorry. Horizontal positions, however, are less likely to accelerate the labor process. When laboring in supine or lithotomy position, woman's weight is mainly supported by her back, which requires woman to push against gravity and puts the fetus in a favorable drive angle in relation to pelvis. Contractions are frequent but less effective in supine or lithotomy position, and more pain and less effective uterine contractions, maternal exhaustion due to prolonged labor. We all want that labor to be short, but we have to acknowledge that for the first time mothers, birth can take some time. And we do not need to speed up too much. We need to give enough time to the mother and support her and to say that this is normal, this is a normal time frame, there is no time to rush, and all this time given to the mother, it's really empowering her, because then she feels that she's a driver of her birth. Then another adverse effects are like it reduces pelvic outlet diameters and reduces blood flow to the uterus, resulting in fetal hypoxia. Lithotomy position has been identified as a risk factor for severe perineal tears. I was talking about second-degree tears in upright position, but this upright position, they do not increase severe perineal tears. Severe, that means third or fourth degree tears. When mother in lithotomy or supine position, she's more likely will have this severe tears. So how we can facilitate upright positions in your birthing unit, in your labor rooms? As you see in the picture, there's nothing like really much. It's just like some mattress on the floor, some big bean bag, then peanut ball, gym ball, armless chair, and mother, if you can notice, mother is kneeling by the side in this colorful room. Yes. And this is how, she is allowed to find her space. This is how she is, she tried every of this equipment, but finally she adapted herself in this position, and we allowed her to be like that. yes, supporting and gently coming to ask how she's doing. And we allow her to be in her bubble, in her powered space. When you think about creating this environment, so think where you can, and how you can facilitate that. And have this equipment ready. And you can improvise, like I today just improvised with few chairs, and it's not that difficult, You just need to allow, even the table can be used for her leaning forward so she can rest on it. What else is important? Prepare woman and her birthing partner antenatally. Karen already talked about these exercises. When woman knows from antenatally about these different exercises, different positions, so she is much easier to accept. If you offer her different positions, she will be happy to go on it. And then I noticed that they go and they use these techniques what they learned during pregnancy. And encouragement is very important. So midwife and her birthing partner has to encourage mother and to support her and say, yes, you can do it. Yes, you can do it, just for her to trust her body. Because there are the certain moments during birth when women say, I can't do that anymore, I'm going home. But they, and that point, when is the maximum of her stress and pain, the birthing partner should be there, midwife should be there to reassure her, to encourage her, and to be with the mother. Eye contact is very important, talking to mother kindly, be compassionate, and really be with women. That's what midwife means, being with women. If you just come and go, there is no connection with the mother. This nurse, midwife should be present with the mother all the time. And this midwife should have a knowledge of this different position, feel competent, and not to be afraid of different positions, and be knowledgeable and competent in conducting birth in these different positions. But and you see, the encourage mobilization, be knowledgeable in assisting women in birth in non-supine positions. Here you can see some antenatal exercises in our MLC unit. This squatting, I really like to see this. This mother, after this exercises, actually she went into labor and very soon she delivered her baby. So just doing all this, she came just with few niggles, and after some time she progressed into the proper labor. So lots of researchers supporting upright position, and lots of researchers not supporting lithotomy and supine position. But why still mothers, women, they deliver lying on their backs? Why is it happening? When this happened, it's just like a few hundred years ago, historically, when some doctor just decided to use forceps to deliver baby, this supine lithotomy position was used. Then someone wanted to observe this birth, that king, yes? So then this was also, mother was put in lithotomy position just because man wanted to observe, and it was more convenient for them to assist the birth. So that's why it started like culturally, and then it's like very quickly went around the world, this position, because it was more convenient to the caregiver, but it's not more comfortable for the mother. And this each, research was done in India too. And look what it says, that 92% of labor and delivery nurses were aware of upright birthing positions. 83% of them believe that women should have a choice of upright birthing position. But 100% of nurses said that lithotomy was the most common birthing position. Why it happened? The reasons are there: ease and convenience and overcrowding in the labor room were the most common reason for not allowing patients to use the birthing position of their choice. Other reasons for not using upright position. This was the feedbacks from the mothers and the midwives during the study, and it said like mother were instructed to do so by the nurse midwife, and then she believed that supine position is the universally known and practiced birthing position. Then it provides flexibility to continuously monitor the progress of labor and assist delivery more efficiently. So when we monitor baby, especially with the continuous fetal monitoring, the CTG, mother normally lies on her back, and this restricts her movements. Then birthing, this nurse midwives, they were feeling like they are incompetent due to lack of training, and then lack of experience as well as knowledge, and obviously defensive practice. In the same study of nurse midwife in Tanzania, saying that if a mother insisted on pushing or birthing in upright position, the mother was labeled as uncooperative. Did you hear this? I heard in India so many times when the nurse comes and says, oh, this woman, she is incooperative. Just because that woman wants her labor to happen her way, not the way how the doctors want it to happen. So she is labeled, and it's so easy to put this label on the mother and say she's uncooperative. And sometimes then these mothers are not even respected just because she wants her birth to be the way how she wants it to be. So now, just to support this changes, what we are doing in our midwifery-led care unit, we integrate nurse practitioners from labor room one by one. We call them to come to our midwifery-led care unit and stay with us and observe and see. So I really love this picture because you can see this nurse practitioner with the white coat, and then two NPMEs. They are supporting mother in squatting position. Can you see the position in which they are? All of them, they are in squatting position too. Yes? So this is the very important point, because, you know, if you want to support mother who is squatting or kneeling, this nurse practitioner has to go on her knees too. That's very important to understand. And it's very difficult to achieve this. That's why all these mothers, they are put on this, beds, which is on that level, which is convenient for caregiver, but not for the mother. So if we go a little bit more further, um, you can see that government of India supports World Health Organization recommendations. And in 2018, the government of India launched the midwifery service guidelines in India with the overall goal to develop cadre of nurse practitioner in midwifery who is skilled and in accordance to competencies prescribed by the International Confederation of Midwives, who is knowledgeable and capable of providing compassionate, movement-centered, reproductive, maternal, and newborn health care services. The Midwifery Service Initiative of India is this program started nationwide in various states are at the different stage of implementations. The training cascade was followed, like already Karen told in the previously, that nurse practitioner midwifery educators are trained by international midwifery educators and national midwifery educators in national midwifery training institutes as per international Indian Nursing Council curriculum. Then national practitioner midwifery educators started training nurse practitioner midwives in state midwifery training institutes. So it's a cascade of it. So competency-based training is a core method which enables the nurse practitioner midwives educators to demonstrate knowledge, skills, and behavior based on evidence-based knowledge, women-centered, respectful maternity care. And already a few government-supported MLC units established across the country. In a conclusion, I would like to say that quality maternity care midwives provide through the midwife-led care units is vital to the transformation. Nurse midwives must take the lead in the birthing process to empower women to get a positive childbirth experience and provide care that includes a choice of birth position, information concerning different birthing positions, autonomy and empowerment, and holistic, respectful, continuous maternity care. And here resources used. And here is a happy mother. Thank you.
Thank you, ma'am, for imparting your wisdom with us. Now, I would like to request our principal, ma'am, Dr. Archana Chauhan, ma'am, to present a memento to uh, Miss Renata Grablinian. Thank you, ma'am.
Everybody is looking quite exhausted. Am I right? Okay. So for your refreshment, we are having tea break now, and everybody has to stay on their seat only. We are serving tea on your seat only. And after that, we have our cultural event to be in continuity. Curtain band kar do. So everybody are requested to stay on their seat only.
A very A very good evening, all. A successful team is a group of many hands but one mind. I am Sanjana Ojha.
And myself, Anshika Nandan, nursing tutor of this college.
We delighted to be your host for this cultural event. A warm welcome to all of you. It's great honor and privilege to welcome you all this event, which is organized by our college, Baba Educational Society, Institute of Paramedical, College of Nursing. I would like to express my sincere gratitude to our delegate, director sir, principal ma'am, teachers, and all students.
Indian,
Hmm.
Indian culture is an important part of our lives. It helps to grow our personality and our roots. This is the most awaited session of every event. Within a few minutes, we are going to watch and enjoy gorgeous performance. So inhale and hold the evening in your lungs. सौ चांद भी आ जाएं तो महफिल में वो बात न रहेगी सिर्फ आपके आने से ही इस महफिल की रौनक बढ़ेगी Thank you. Claps are the best motivation that you could give our young lads. So without wasting further time, let's watch out Ganesh Vandana. हाँ Sorry for inconvenience. Let's watch out Marathi dance.
जीव झाला येडा पिसा त्याचा नाही भरवसा तोल राहीना राखली ती मर्जी तुमच्याच वडीन मी आले फिरतीच्या या रंगीराया चिंबोरी मी झाले राया सोडा तरी काळ येळ नाही तरी काळ येळ नाही बरी पुन्हा भेटू कवा तरी साजना मला जाऊ द्या न घरी 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 वाचले की बरं मला जाऊ द्या न घरी वाचले की बारा लटपट लटपट कमर दामिनी अधर रागिनी हो लटपट लटपट कमर दामिनी अधर रागिनी मेरे घर आई कैसी सजी धजी देखो मेरे पिया की सावरी जिया से बावरी मेरे अंगना में देखो आज खिला है चांद ये माझ्या धुन छम छम छमाके छम तुझे मन छम छम छमाके छम ये माझी धुन छम छम छमाके छम तुझे मन छम छम छमाके छम लटपट कमर दामिनी अधर रागिनी मेरे घर आई कैसे सजी धजी देखो मेरे पिया की सावरी जिया से बावरी मेरे अंगना में देखो आज खिला है चांद ये माझी धुन छम छम छमाके छम तुझे मन छम छम छमाके छम ये माझी धुन छम छम छमाके छम तुझे मन छम छम छमाके छम पिंगा ग पोरी पिंगा ग पोरी पिंगा ग पोरी पिंगा पिंगा ग पोरी पिंगा ग पोरी पिंगा ग पोरी पिंगा पिंगा ग पोरी पिंगा ग पोरी पिंगा ग पोरी पिंगा पिंगा ग पोरी पिंगा ग पोरी पिंगा ग पोरी पिंगा
Your hands and giving them a best round of applause. ये क्यों बीच में बंद कर देते हैं?
Now hold your excitement for the next very energetic performance. That is Ganesh Vandana.
ज्वाला सी चलती है आंखों में जिसके भी दिल में तेरा नाम है, परवाह ही क्या उसका आरंभ कैसा है और कैसा परिणाम है। धरती अंबर सितारे है, उसकी नजरें उतारे, डर भी उससे डरा रहे, जिसकी रखवाली यार करता साया तेरा। हे देवा श्री गणेश देवा श्री गणेश देवा
गिली 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 हाँ हा 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 गिली गिली माटी के चल घराते बनाएंगे रे हरी भरी अम्बी की डाली मिलके झूले झुलाएंगे रे वो धन बैजू गजने हल जोते सबने बैलों की घंटी बजी और ताल लगे भरने रे तैर के चली मैं तो पार चली रे तैर के चली मैं तो पार चली पार वाले पर लेके नार चली रे मेरा नन्ना रे 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 नन्ना रे
बजने दे धड़क धड़क ढोल ताश धड़क धड़क भंडारा झिड़क झिड़क मल्हारी धड़क धड़क भड़क सली चटक मटक फटक सली दुश्मन की देखो जो फट लावली बजने दे धड़क धड़क ढोल ताश धड़क धड़क भंडारा झिड़क झिड़क मल्हारी धड़क धड़क भड़क सली चटक मटक फटक सली दुश्मन की देखो जो फट लावली बजने दे धड़क धड़क ढोल ताश धड़क धड़क भंडारा झिड़क झिड़क मल्हारी धड़क धड़क भड़क सली चटक मटक फटक सली दुश्मन की देखो जो फट लावली धीरे धीरे बड़ी चली जो थी चिंगारी छोटी चिंगारी भरी 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 है मन की अलमारी आज अलमारी हुई सतरंगी चाली सतरंगी हुई सतरंगी थी जो ये रात काली चटक मटक फटक साली दुश्मन की देखो जो फट लावली चका 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 चौम अपनी बसती रे साली बसती रे रपा 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 रप सारे मस्ती में डूबे मस्ती में बड़ी अतरंगी हुई अतरंगी बड़ी अतरंगी अपनी ये जीत साली करक दरक भड़क सली चटक मटक फटक सली दुश्मन की देखो जो फट लावली धड़क धड़क ढोल ताश धड़क धड़क भंडारा छिड़क छिड़क मल्हारी धड़क धड़क भड़क सली चटक मटक फटक सली दुश्मन की देखो जो फट लावली बजने दे धड़क धड़क ढोल ताश धड़क धड़क भंडारा छिड़क छिड़क मल्हारी धड़क धड़क भड़क सली चटक मटक फटक सली दुश्मन की देखो जो फट लावली
Hello. ब्यूटीफुल परफॉर्मेंस। अपनी कदरदानी को इस तरह ना छुपाइए। अगर डांस पसंद आया हो तो तालियां बजाइए। ठीक है, नेक्स्ट। ठीक है, परफॉर्मेंस नेक्स्ट परफॉर्मेंस इज डोलिना। आर यू रेडी गाइस?
प्यार के गीत जरा सुन ले, ओ प्यार के गीत जरा सुन ले, मैं आया रे।
मन मचल के मोर होना चाहिए, इस शानदार सी शाम में थोड़ा शोर होना चाहिए। दिखाने के तो हम रात भर डांस दिखाएं आपको, मगर आपकी तालियों में भी तो थोड़ा जोर होना चाहिए। So let's watch out Ghumar dance.
साजन जीव जड़ी साजन फूल गुलाब रो सूंघू घड़ी घड़ी ओ जी केसरिया बालम पधारो मारे देश रे पधारो मारे देश रे
ना जाओ जी मन दीद कराओ जी अरे क्यों तरसावे हो मन शकल दिखाओ जी हरी शरारत सब जानू मैं तो धरी हर सले मन भंगा दी मैं कह लगे मर टिबड़ में जागी दो कणी है चंदा में थारी चांदनी मन दामन में भा एक सीरे झुम 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 हमारे टिबड़ में जागी दो कणी है चंदा में थारी चांदनी मन दामन में भा एक सीरे झुम 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 झुम
What a performance.
बिन बूंदों के बारिश का एहसास कैसे होगा, जुनून हो दिल में जिसके वो हताश कैसे होगा।
कार्यक्रम के इस रंग का मिजाज कैसा है, बिन तालियों के हमें एहसास कैसे होगा। Let's move to next dance, that is retro.
आओ हुजूर तुमको सितारों में ले चलूं, दिल झूम जाए ऐसी बहारों में ले चलूं। आओ हुजूर तुमको सितारों में ले चलूं, दिल झूम जाए ऐसी बहारों में ले चलूं। आओ हुजूर मुझको हुई न खबर, चोरी चोरी छुप छुप कर मुझको हुई न खबर, चोरी चोरी छुप छुप कर। अब प्यार की पहली नजर है, ले गई ले गई दिल, ले गई ले गई, ले गई ले गई दिल, ले गई ले गई।
ये चांद का रोशन चेहरा, जुल्फों का चांद का रोशन चेहरा, जुल्फों का रंग सुनहरा, ये झील सी नीली आंखें, कोई राज है इनमें गहरा।
ये चांद सा रोशन चेहरा, जुल्फों का रंग सुनहरा, ये झील सी नीली आंखें, कोई राज है इनमें गहरा। तारीफ करूं उसकी जिसने तुम्हें बनाया, उसकी जिसने तुम्हें बनाया। गोरी 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 गोरी, कभी कभी कहीं कहीं चोरी चोरी, छुप छुप के तुम मिला करो, प्यारी प्यारी बातें बातें किया करो, पर यूं ना मिलना किसी से कभी हमारे सिवा।
गोरी 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 गोरी, बोले बोले नए नए गोरी गोरी। देखो देखो हम दोनों मीते हैं, सुन सुन दिल की चुपकी से है, पर सुन नहीं पाए इन्हें ना कोई हमारे सिवा। डिंग डंग डिंग डिंग डंग डिंग डंग डिंग डंग डिंग डंग डंग डिंग डंग डिंग डंग। चार पाँच छः सात आठ और 10 11 12 13 12 13
आजकल तेरे मेरे प्यार के चर्चे हर जबान पर, सबको मालूम है और सबको खबर हो गई। आजकल तेरे मेरे प्यार के चर्चे हर जबान पर, सबको मालूम है और सबको खबर हो गई।
आई हो कहाँ से गोरी आंखों में प्यार लेके, आई हो कहाँ से गोरी आंखों में प्यार लेके, दिल्ली शहर का सारा मीना बाजार लेके, झुमका बरेली वाला कानों में ऐसा डाला, झुमके ने ले ली मेरी जान। हाय रे मैं तेरी कुर्बान। बोले चूड़ियां, बोले कंगना, हाय मैं हो गई तेरी साजना। बोले चूड़ियां, बोले कंगना, हाय मैं हो गई तेरी साजना। तेरे बिन जिया नहीं लगता मैं ते मर गईया। लचा लचा सोनिए लचा लचा, दिल लचा लचा
देखो देखो है शाम बड़ी दीवानी, धीरे धीरे बन जाए न कोई कहानी। देखो देखो है शाम बड़ी दीवानी, धीरे धीरे बन जाए न कोई कहानी। दिल पर है दिलकश है दिलदार नजारे हैं, आज ज़मीं पर उतरे कितने सितारे हैं। अगलो रोशन में दानम, हम है दिल है और जानम, बस दीवानगी 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 है। ना कोई रहसन ना रहबर, ये इल्जाम लगे किस पर, बस दीवानगी 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 है। All hot girls put your hands up and say, Om Shanti Om. All the cool boys in the world make some noise and say, Om Shanti Om.
कानों में खनकती है खूबसूरत बालियां, मजा तब आता है। कानों में खनकती हैं खूबसूरत बालियां, मजा तब आता है जब महफिल में बजती हैं तालियां। Thank you. So next performance is Bengali dance.
कानों में कनकती है सब
ढाक
awesome performance. मीठी बात और चेहरे पर मुस्कान, ऐसे ही लोग हैं हमारी महफिल की शान.
So, next performance is solo dance by Mansi.
पैरों में तेरे घुंघरू की बिजुरिया छन 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 गाती रे अनछन चली बोलो जाती रे जाती रे अनछन चली बोलो जाती रे जो हो जाए आज हो जाए अरे घुंघरू चाहे टूट ही जाए आंधी आए तूफान आए या अम्बर झुक जाए अरे बन ठन चली देखो रे जाती रे बन ठन चली देखो रे जाती रे
तू होगी 1 2 2 ओ कुड़िए what to do ओ हो गई मुंडे दी पतंगा वर्गी तू एवें उड़दी ओ हो गई मुंडे दी हिला ते चलदी टुक टुक तू करदी मेकअप तू कर दिया अंग्रेजी पढ़दी किट पिट तू करदी जिम्मे क्वीन साडी विक्टोरिया तू कैंटी बिग बैन दी पूरा लंदन ठुमकदा ओ जदों नच पैन दी पूरा लंदन ठुमकदा तू कैंटी बिग बैन दी पूरा लंदन ठुमकदा
रंग बिखरा बिखरा सब निखरा निखरा जाए जिधर जिधर ये नैना मुझे खुद पे नाज हुआ पगला आज रहा अपने ही बस हूँ मैं ना रंग बिखरा बिखरा सब निखरा निखरा जाए जिधर जिधर ये नैना मुझे खुद पे नाज हुआ पगला आज रहा अपने ही बस हूँ मैं ना माना मुझे बस कर लेना ना जा हंस कर लेना तू चारों ओर शहनाई शोर तू मेरी ओर चल निकला चढ़ प्रेम लोर को दिल के जोर कर मेरी गुलाब दिखला रांझना हुआ मैं तेरा कौन तेरे बिन मेरा रौनकें तुम्हीं से मेरी कौन तेरे बिन मेरा तेरा है चार चुफेरा ओ कौन तेरे बिन मेरा हुआ चारों ओर शहनाई शोर तू मेरी ओर चल निकला चढ़ी प्रेम लोर को दिल के जोर कर मेरी भोर मुख दिखला
आई खुशबू फूल तो फूल है कांटों से भी आई खुशबू.
Without wasting our time, we move on the next performance. That is Ore Piya.
ओरे पिया ओरे पिया ओरे पिया ओरे पिया ओरे पिया ओरे पिया उड़ने लगा क्यों मैं बाबला रे आया कहाँ से ये हौसला रे ओरे पिया वो चांद की उतार ली है दोनों बालियां वो चांद की उतार ली है दोनों बालियां आजा आजा हाथ मार दे तालियां चांद की उतार ली है दोनों बालियां आजा आजा हाथ मार दे तालियां ओ दिलों ने हाथ मार दे तालियां दिलों ने हाथ मार दे तालियां आजा चांदनी कूटेंगे आसमान को लूटेंगे चल धुआं उड़ा के झूम 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 बराबर झूम बराबर झूम बराबर झूम बराबर झूम बराबर झूम बराबर झूम झूम बराबर झूम बराबर झूम बराबर झूम झूम बराबर झूम बराबर झूम बराबर
Hello.
Putting your hands together, giving them the best round of applause. Thank you. Next one. Now hold your excitement for the very energetic performance, that is Punjabi dance. चलिए स्टार्ट करिए.
जाए आसमां से तारे ना बिंद किया तू ऐसे चमका
गले गले रहना मुझे अच्छा लगदा जो भी तू कहे सारा मुझे झूठा लगदा तुम मेरे जैसा मिले कर दे तू कुछ
अंग्रेजी म्यूजिक में दे दे तू पंजाबी सारी दुनिया में जी हिट है पंजाबी
सोना सोना रंगीन जामा देखा
से तू नचे होए तमाका जी तू मचे सारी दुनिया में जी हिट है पंजाबी चाल मेरी जान जाती है दिल जो पास आती है तेरी चाल मेरी जान जाती है
Get ready for heavy dose of entertainment. That is Pallu Latke. That is Pallu Latke. Okay.
Drop the bass.
दो तले की मंदिरे लादे तीन तले का कंगना मुंह दिखाई दे दे फिर तू ले जा अपने अंगना दो तले की मंदिरे लादे तीन तले का कंगना मुंह दिखाई दे दे फिर तू ले जा अपने अंगना ना समझ जो चीज पुरानी चेहरा मेरा इस नूरानी देखेगा तो भाग जाएगा सो झटके लटके मारो पल्लो लटके जरा सा टेढ़ो हो जा बालों
जान कट जानी है
Can I expect a huge round of applause?
आप लोग जाइए नहीं, अभी हमारे पास 2-3 डांस और बाकी हैं आपके लिए।
मेरा झुमका उठा के लाया यार वे जो गिरा था बरेली के बाजार में मैं तो ठुमका लगा के शर्मा गई बोली घूम कर बजाने के मैं आ गई मुझको लगा के नाच ले बोली घूम कर बजाने के मैं आ गई मुझको लगा के नाच ले आजा नाच ले मेरी यार तू नच ले झनक झनक झनका हो नच ले मेरे यार तू नच ले अब तो लौटा है बाजा सबको बुला के नच ले आजा नच ले मेरे यार तू नच ले झनक झनक झनका हो नच ले मेरे यार तू नच ले अब तो लौटा है बाजा नचले जरा नचले छत पे उठा के 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 नचले मैंने गलती करी थी मेरी नथनी पड़ी थी मैंने गलती करी थी मेरी नथनी पड़ी थी कि सोने में उसको रंगा गई मैं रंगा के अटरिया पे आ गई मोहल्ले में कैसी मारा मार है मेरे दर पे दीवानों की बहार है
Next dance is solo dance by Preeti.
आगे तोड़ना चांदनी से नूर के, घूंघट ही बना लो रोशनी से नूर के।
शर्मा गई तो आगोश में ना हो, सांसों से उलझी रहे मेरी सांसें।
बोल हल्के हल्के, बोल हल्के हल्के, मुझसे हल्के हल्के, बोल हल्के।
तेरी मस्तानी अनजानी बातों को मेरा सलाम, रंगों में डूबी डूबी बातों को मेरा सलाम। रस बूंदिया नयन पिया रास रचे, दिल धड़ 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 के शोर मचे, यूं देख सेक सा लग जाए, मैं चल जाऊं बस प्यार बचे।
मेरा झुमका उठा के लाया यार वे, जो गिरा था बरेली के बाजार में। मैं तो झुमका लगा के शर्मा गई, बोली घूमकर बजाने के मैं आ गई।
मैम बोल रही है, मैं कहने के लिए लेट हो गया, टाइम बहुत हो गया ना, नहीं बस लास्ट घरमुरे परदेसिया। हाँ, लास्ट परफॉर्मेंस इज घरमुरे परदेसिया। थोड़ी देर और वेट कर लीजिए, आप इससे ये नहीं देखा तो आपने कुछ नहीं देखा।
रघुकुल रीत सदा चली आई, प्राण जाए पर वचन न जाए। दरदाना तेरे नाम का दीवाना, दरदाना तेरे नाम का दीवाना। रघुवर तेरी राह निहारे, रघुवर तेरी राह निहारे, सातों जन्म से सिया घर मोरे परदेसिया। चलते 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 यूं ही कोई मिल गया था, यूं ही कोई मिल गया था। सरे राह चलते चलते, सरे राह चलते चलते वही थमके रह गई है, वही थमके रह गई है। मेरी रात ढलते ढलते, मेरी रात ढलते ढलते। चलते चलते
Thank you to all our participants for their beautiful performance, and we hope you all have been recharged. रिचार्ज हुए ना आप लोग वापस से? बिकॉज कल हमारा कंटिन्यूटी है, सेकेंड डे ऑफ इंटरनेशनल कॉन्फ्रेंस, एंड आप सबको वापस से आना है, इसलिए अभी आप लोग रिचार्ज होके जा सकते हो। ठीक है, तो फॉर टिल देन एक अनाउंसमेंट है कि अगर आप लोग लखनऊ में आए हो, वेलकम टू द सिटी ऑफ नवाब, एंड आप लोग एक्सप्लोर कर सकते हो बहुत सारी चीजें, जैसे कि हमने अपने ब्रोशर में ऑलरेडी मेंशन कर रखा है, लाइक अंबेडकर पार्क, रूमी गेट, इमाम बाड़ा, लोहिया पार्क, अमीनाबाद मार्केट, गोमती रिवर फ्रंट, and you can also explore local market of Lucknow and mouth-watering Lucknow cuisine. So enjoy your day, enjoy your evening. Thank you.